Now we'll get started. Now we're good. Laura and Brandon and I get to talk to you today about some biotechnologies that are empowering patient-centered care, some of the challenges that we've run into, and how we created some middleware to solve those challenges. We've worked with a lot of really great people along the way, and so we'll get to mention them as well. So first we'll talk about two different apps. Then we'll talk about how we used this middleware option to integrate these standard-based services through the apps with a non-standards-based environment. And then hopefully we'll get to do an app walkthrough for each app. And if not, we have some screenshots and they're also in the slides. So if you are with us virtually and the app walkthrough doesn't come through clearly, you can take a look at those screenshots as well. All right, so the first app that we get to talk about is this clinical decision support for chronic pain management, or CDS for CPM for short. So this is an AHRQ project, and it's a two-app system. So My Pain, which is patient-facing, and Pain Manager, which is provider-facing. And it's supporting patient-centered care and shared decision-making encounters for patients with chronic pain. Another AHRQ supported project co-funded along with NIDDK, National Institute of Diabetes and Digestive Kidney Diseases, is the eCare Plan apps. These apps also provider facing and patient and caregiver facing, so two different sides of this. So the eCare Plan app is pulling together all the different data needed for care coordination for patients who have multiple chronic conditions and therefore are seeing many different providers and may also have different caregivers and different entities that need to interact with their care plan outside of their outside of the health system. All right, so now I'm going to let Laura take it over. Oh, I'm sorry, Brent.
So I'm just going to speak about the architecture that we put in place for this CDS for CPM system. So as Sarah mentioned, it's two applications. One is a patient-facing Smart on FHIR application that enables the patient to fill out a FHIR questionnaire and send those responses back. Ideally, that happens sometime before the encounter. So they're given like a notification or a reminder as part of the reminder for their appointment. They're given a link to that application to fill that out. And then there's Pain Manager, which is the provider-facing aspect. That happens during the encounter, where the clinician is able to pull up a Smart on FHIR application that has access to the information the My Pain application provided when the patient answered the questionnaire. So what we needed in that case was a FHIR system that could accept questionnaire response. So questionnaire response is the main resource that we were using to capture the answers to those questions. And we didn't have a way to support that at the time. The FHIR server we were using didn't have that API available, that endpoint. So the architecture was to put a FHIR facade in place that stands in front of the FHIR server that's at the site. And for most things that are already supported, it's just pass-through. It's like, but if it's something that's not supported, it can provide additional capability. So in this case, when we posted the questionnaire response to that facade, it actually turns it into observations that can then be written back to the underlying FHIR server. And the observations is how the pain manager is actually able to read it. So this facade is a way for us to, by still expressing the capabilities in the applications in pure FHIR standard form, get some additional capability out of the environment that isn't necessarily supported by the native FHIR servers. So that's the architecture there. No, hand it to.
Yeah, so just by comparison, we built also an AHRQ-funded project looking at care coordination for people living with multiple chronic conditions, the e-care plan system. In this case, the FHIR middleware also could be called a FHIR facade, but did significantly less. So in this situation, what we were trying to do is support care coordination, also a patient-facing app and a provider-facing app. And the goal, of course, was to try to maximize what we could in terms of the native epic FHIR endpoint. And to do that, we had a pretty exhaustive list of data elements that we were trying to support. And ultimately, we really focused on suppression in that middleware layer. So in order for the app to make an R4 request that wouldn't be fulfilled with an R4 response, we had to suppress some of those requests. And so very different kind of approach. The advantage was that we could get the applications working, we could demonstrate the capabilities with the native Epic FHIR API, and we could then document where things break, where things, these requests can't really be fulfilled. We are working on another version of this. We're learning from what we did on the CDS for CPM project, and we're looking at capturing patient-recorded outcome measures and how to store those. In the case of CDS or CPM, we did the write back directly to the electronic health record, but using proprietary APIs. In this case, we're thinking of doing some type of research data store is how we're describing it. And we're also thinking about building a more robust FHIR facade-like infrastructure to fulfill some of the requests that we couldn't in the first round. And this is we piloted that application at OHSU. And I guess I'll flip with you and I'll do these. Okay, so just really quickly, what did it look like? Not totally wonderfully easy to see, and certainly not a super user-friendly interface. So the first iteration, I'd say, was totally focused on what are the data elements of interest, how are they actually available, how do we represent this information in the sort of barest bones manner, and then how do we get some feedback and kind of move into a more user-centered design approach. So in the second round, we're definitely working on that. But you can see here a little bit of demographic information in the header. You may not be able to read these, but the tabs are health and social concerns, goals and preferences, health maintenance and interventions, health status evaluation and outcomes, and care team. So in the pilot, we've learned a lot about the use of language and the order of presentation, the ability to kind of control how things are presented. But the win themes were that we were actually able to integrate this application test with it and really find out some of the challenges. So these are just sorry for the truncation on your left, but some of the information that is conveying successfully in each of these categories. These are test patient profiles. So you see some of the members of the project team sort of expressed by members. So, all data that we built to try to maximize the opportunity to display information relevant to the problem, the multiple chronic condition patient. And again, just extending into drug information or medication information. We did do a little bit with visualization. I think some of that was successful, and some of it wasn't. Like change in weight over time for an individual doesn't look like much of a change when you do it on a sort of grander scale like that. And then a little bit about the care team. Most of this, what you see here, is the provider-facing application. The patient-facing application in this round looks very same data, same basic information, but slightly different presentation, more app style.
Okay, and then we'll just do a quick walkthrough of the CDS for CPM app. So this starts with the My Pain application. This is a Smart on FHIR application that is just rendering a FHIR questionnaire resource. So most of the content here is driven by the definition in the questionnaire. So the fact that it's showing head and neck and shoulders is a result of those are the questions that are defined by that resource. And that was important because it let us quickly change the questions that the clinicians wanted answered in that pre-visit questionnaire. So things like the intensity, the choices that are listed there are again enumerated in that questionnaire resource. And you can see there's visual feedback to the user about how far along they are in the questionnaire. And once they fill that out, this is sort of a long questionnaire, but once they fill out the whole questionnaire, sorry, this is the first time I'm going through these slides. So they can also provide free text feedback. There's an about my goals, and then there's also multimedia questions where they're actually directed to resources about pain management. So managing chronic pain, the 4 flat tires video. I don't know if you've seen the references to that, but they're pain resources for patients living with chronic pain. And then we captured a really important one, feedback about the questionnaire. So that was important to our kind of evaluation of how the project was working. That was one kind of key data point that we tried to collect. Using the tool helped me begin preparing for a conversation with my provider to try to get some answers about that as well. And then any kind of overall feedback that they had. Additional pain locations, additional treatment options. We optimized the capture of goals. And when that information is submitted, like I said, we turn that into observation information in the FHIR server when that was submitted. And then when the provider is able to, when the provider launches Pain Manager, then they're able to see those responses to that based on those data coming back. So activity goals, they're able to see what the patient actually said, the pain locations, all organized here based on those responses. We also, so the Pain Manager is actually a customization of the AHRQ pain management dashboard, which is an older application. And by that, I just mean it was created a while ago. But it's a pain management summary dashboard. It's just bringing in additional and relevant information about managing chronic pain, factors to consider. And we were able to quickly adapt that Smart on FHIR application and just add this capability that we needed. Current pertinent treatments, and it's basically providing cognitive support for the recommendations in the CDC opioids prescribing guideline. So, don't co-prescribe benzodiazepine, look at urine drug screening, all the different factors there. So that's a quick walkthrough of the CDS for CPM. I think that's it.
So we do have a few questions from the virtual attendees. I'm not sure if anybody here has questions. So I'll go through the first one. The first one was, Bryn, I think when you were presenting the architecture, did you say a patient-facing Smart on FHIR app? And then what database on the patient side does it connect to? I would expect the Smart on FHIR stuff to be on the organizational side and the patient to get a mobile app using FHIR APIs.
Yes. So the MyPain, let me go back to the architecture slide there. Yeah, the MyPain application does not have any additional storage requirements. It's using, it's this patient-facing Smart on FHIR application. It uses the FHIR endpoint that comes through the Smart on FHIR context. It's authorized through that process. And it doesn't use it doesn't have any additional storage requirements. It's retrieving a questionnaire and it's posting a questionnaire response. That's really the only, it does get the patient resource, but that's the only requirements the only data requirements it has. And the fact that it's using questionnaire and questionnaire response is enabled by this FHIR facade. And the FHIR facade is doing pass-through authorization for the OAuth and for everything else that the pain manager and the MyPain applications need. The facade is only handling the questionnaire and questionnaire response, and it's turning the questionnaire response right into observation rights against the underlying system. So there's no additional requirements there. And that link to that application is distributed through the patient portal of the site. So.
Okay. Second question was, since folks with diabetes are more likely to have vision problems, how are you supporting low vision patients who typically cannot use patient portals, which is listed as a required?
That is a great suggestion. We are, so in round one for the eCare plan project, we really didn't engage patients much. I mean, we did more than we did for CS or for CPM by testing with patients who might fit the profile. But in the upcoming round, we'll have an opportunity to really engage patients who more represent the total profile and to actually embed and change some of the sort of usability aspects of the application as a result. So great point.
Okay, and the last question from the virtual, hopefully it's not a loaded one. Are you really putting that much content on a single screen? That seems like a major usability issue. Can the user control that, especially if they have vision or mobility issues?
I'm assuming that's an eCare plan question as well. I mean, I think it was a kit of parts. You know, I think the goal was to get as much information out there and to see how much of a connection we could make using the existing FHIR API. But definitely, we're back to sort of the drawing board on how to make the visual presentation better and prioritize information as well.
Okay, we're a minute late. If anyone does still have questions, feel free to post them in the Whova Q&A portion of this session. And then I always remind our speakers, hop into your sessions in Whova, check out the Q&A to see if there's any unanswered questions. I marked these as answered, so you don't have to worry about them. But anybody here, even face-to-face, feel free to post them there as well. Thank you.